start off talking about what ACOG has in their group of guidelines that they publish. So you can go to their website and find them. They have a book called Guidelines for Perinatal Care that's now in its 7th edition that talks about how L&D should be run, about peripartum care. And they have what they call the compendium. And the compendium is this giant, when it was in paper form, it was like 3 inches thick, of all the committee opinions and practice bulletins and things like that that ACOG has out there. So I just want to show you a couple. Probably one that we're all familiar with is the VBAC guidelines. The VBAC guidelines were sort of sprung on us about a decade ago now, and really caused a lot of consternation because it said that everyone needs to be immediately available if somebody's having a trial of labor. Not a practical thing to do if you're not normally in-house all the time. So in 2010, ACOG got a lot of criticism. There was an NIH consensus conference to look at C-section rates in general and specifically how VBAC was impacting that. And they made the point that yes, trial of labor and elective cesarean have risks, but maternal mortality is significantly higher after an elective repeat section than after a trial of labor with a successful vaginal delivery. And you can see 13.4 versus 3.8 deaths per 100,000. And they made the point that it is ACOG's immediate availability statement in the VBAC guidelines that have forced many women to undergo a riskier procedure than they needed to have. Those are strong statements. About the same time, a couple of studies were published showing that neonatal outcomes are also worse after an elective C-section than after a successful trial of labor with a vaginal delivery. So there were higher NICU admission rates, higher perinatal mortality, still very low, but nonetheless significantly different between the two modes of delivery. And of course, cost is much higher if a woman has a C-section than if she has a vaginal delivery. Yes, there is a risk of uterine rupture during a trial of labor that is higher, and those things have to be measured. But it seems that both for mother and for baby, the safest thing for them is to have, hopefully, a vaginal delivery rather than an elective repeat section. So because of those things, ACOG went back, they revised the VBAC guidelines again, and they did liberalize them a fair bit. So they pointed out that, yes, we can give you an overall success rate for a VBAC, but there are a lot of individual factors that go in. So you can go online and find all kinds of algorithms now that let you give a woman, for your conditions, things like why you had a previous section, your age, your parity, things like that, and give her a very specific quote. Here's the chance you will have a successful vaginal delivery specific to that patient. They now say that women who've had 2 prior C-sections can also labor. Women who have twins in a prior section can labor. You can try a version with a scarred uterus to see if you convert her to vertex. Induction is an option as long as you don't use misoprostol or Cytotec for that induction. They still have in there that a trial of labor should be done at facilities capable of an emergency delivery, and that means the personnel have to be available. The obstetrician, us, nursing, an empty OR like we've been talking about. But the big thing in here is they say, when these resources are not immediately available, patient autonomy supports that patients should be allowed to accept increased risk after they've been counseled. So you present to the patient, okay, in our hospital at 3 a.m. on a Saturday, as Alex was talking about, we're not going to have all these people in-house waiting for you if something happens during your trial of labor. And she says, that's okay, I'll do anything to not have to have another C-section. Then again, respect for her autonomy should allow her to do that. Now, you know, what this is actually going to mean in terms of availability of VBAC around the country, hard to say, but ACOG is at least trying to liberalize and not force patients to have a repeat C-section if they don't want one. Now, postpartum tubal ligation is kind of the, again, redheaded stepchild on labor and delivery in terms of getting it done in the midst of all the other acuity. But what happens to a patient if she requests a postpartum tubal ligation but is not able to get it before discharge? The nurse forgets and feeds her breakfast, or, you know, everybody's tied up doing other things, and she finally throws up her hands and say, oh, forget it, and walks out of the hospital. So in this study, they looked at 3 cohorts. First one asked for a tubal, received a tubal. Second group asked for a tubal, but just never got done, and they got discharged from the hospital. And then those who said didn't want a tubal and were going to use other birth control methods. And what they found is after 1 year, there were no pregnancies in the group that got their tubal they asked for. 50% of the women who asked for a tubal and it didn't get done were pregnant by a year, compared to 22% who didn't ask for a tubal and were going to do something else. So significant risk of unwanted, undesired pregnancy, and we sometimes forget that not all women have control of their reproductive choices. So because of that and other things, ACOG came out with a very strong statement about postpartum sterilization, saying that you should have access to this considering an urgent surgery. And they cite things like this 50% rate of repeat pregnancy in women who request but don't get their tubal, that there's limited time to get it done, so it really needs to be done within 24 hours of delivery, just because if you're going to do the mini lap, you've got to have the uterus still fairly high in the pelvis, at most by 48 hours. And Medicaid, as you all know, if you deal with Medicaid in your hospital, and who doesn't, has the most cumbersome consent process for women wanting a tubal. They have to have signed a consent a month ahead of time, all these kind of things. So ACOG derides them for doing that as opposed to what a privately insured patient would need to do. So we, as part of the team on labor and delivery, need to do our best to get these cases done for a patient who does request it. How about antibiotic prophylaxis? We're the ones hanging it and giving it, right? So ACOG's practice bulletin here recommends antibiotic prophylaxis for all cesarean deliveries within 60 minutes of skin incision, recommending a first-generation cephalosporin. Seems pretty simple, doesn't it? We do it every day for our OR cases. We get those antibiotics in within an hour of skin incision. They go on to say if you have a penicillin or a cephalosporin allergy, you should convert to a combination of Clinda and gentamicin, and that we don't need to use endocarditis prophylaxis anymore for vaginal delivery or C-section in an uninfected patient. But coming back to our routine OR antibiotics, how are we doing with that? So here they surveyed 1,000 ASA members about how they handle antibiotics for a C-section. Only 2/3 of them reported that they routinely gave antibiotics pre-incision. Now think about your quality metrics you get for your main OR cases. Would 66% be acceptable for getting antibiotics in before skin incision? We're surely all above 90% on those in our main OR cases. The others said that they either give it after cord clamp, which is too late to help the mother, or they give it whenever the obstetrician tells them to, which that just grates against me completely. A lot of variability between hospitals, a lot of variability geographically, but surely we can do much better than this in getting our antibiotics in for these moms having a C-section. Now, preeclampsia is another situation where we're going to be involved with these often very ill patients. ACOG, because head bleeds, intracerebral hemorrhage, is the main cause of death in severe preeclampsia, and presumably due to uncontrolled hypertension, has come out with a very, very strong statement that acute onset, persistent, severe hypertension in the pregnant or postpartum patient needs to be considered a hypertensive emergency. You need to get treatment in very quickly because of this risk of cerebral injury. So they go on to say, here's the drugs we want you to use. They go through labetalol dosing, nifedipine dosing. If you don't have an IV, you can always give oral nifedipine that works very quickly and effectively, or IV hydralazine as first-line drugs. In the rare circumstance they fail to relieve the hypertension, emergent consultation with an anesthesiologist. So we are number one in line here, that they call and say, we can't get this pressure down, we need your help, because we obviously know how to use a lot of other effective drugs to get that done. So we are considered part of this hypertensive emergency protocol that you go into. Another big push for ACOG has been thromboembolism. women die of clots. We talked about that before. Pulmonary embolism is a huge issue. So they are making a big push to get thromboembolism prophylaxis on board. And I will point out, I don't know about you all, but my obstetricians have gone Lovenox crazy. Everybody gets it after their C-section, on their way home, they're coming in with it. But they do reference the ASRA guidelines. So ACOG recognizes that we have limitations on the procedures we can do in an anticoagulated patient. So if you read this practice bulletin from ACOG, it very well lays out, here's what the ASRA guidelines are, this is when she can and can't have a regional anesthetic, so that obstetricians will be aware. They recommend the things you can see here for all patients having a cesarean delivery. And then our part of that is to have good, effective pain control on board, so these women can be up and ambulating as quickly as possible. There's no laying around in bed after a C-section. ACOG wants you up and moving and ambulating, and obviously we need to provide good pain control so that can happen. And then fetal neuroprotection, which I'm guessing you're starting to see on your labor and delivery units now. There's a number of very good studies now showing that magnesium bolus, similar to what we would do for a preeclamptic patient, and a baby who's going to deliver early preterm decreases the risk of cerebral palsy. So magnesium is a very good neuroprotective agent for these very preterm babies, and especially the ones who are going to come in and deliver quickly before you have time for 48 hours of steroids to get on board. So the algorithm includes fetuses that are 23 to 32 weeks, and they're likely to deliver within 12 hours. They will get a 4 to 6 gram magnesium bolus, be on 2 grams an hour, again, just like we do for our preeclamptic patients. And an economic analysis showed that because of the improved outcome in these babies, it is very much lower costs and better outcomes. So when you then need to participate in the delivery of this preterm baby, whether for vaginal delivery or C-section, you need to recognize that this woman's going to be on very high dose magnesium and why that's happening. It's not as a tocolytic, it's not because of preeclampsia, it's to protect this preterm baby's brain and give this baby a better outcome. So I'm going to take a break there. That again is kind of the things that ACOG has out there that involve us, that we need to be aware of, that would be impacting the patients we're taking care of. So let's talk a little bit about AWHONN. AWHONN is the Association of Women's Health Obstetric and Neonatal Nurses. So it's kind of the national trade organization for nurses who work on labor and delivery, who take care of gynecology patients, who are the nursery nurses. And this is where their guidelines come from about how they practice. They have a lot of good things, don't get me wrong, but they have just been our nemesis. We have been head knocking with them for 2 decades now. So they have this statement called the role of the RN in the care of the pregnant woman receiving analgesia anesthesia by catheter techniques. Big mouthful there, but basically it's talking about pregnant women who have an epidural and what the nurse can and cannot do. Now before I go into the specifics, I'll just say that these very same nurses can take care of a gynecology patient who has an epidural in and do anything you want with that epidural. On the other hand, for a pregnant patient, a laboring patient, they are far, far, far more restrictive. And I'll just point out that these guidelines have not been endorsed by ASA, by SOAP, by ACOG. They have been endorsed by AANA, and they have been endorsed by the Society of Critical Care Nursing. What they say is that, and this is the 2015 revision, just came out last year, but is basically very much the same as we've had in place. The things that a labor nurse may do with your epidural are to take out an empty infusion syringe or bag and replace it if the pharmacy has it pre-prepared. They can take the catheter out after delivery if you order that as part of your orders, and they can stop the pump if there's some safety concern, trouble breathing, evidence of a high block, hypotension, something like that. But they cannot do anything else. So if you're in the OR and you call up and you say, can you change her rate from 10 to 12 because she's having some breakthrough pain, the nurse is going to say, no, I can't do that. And this is why, because AWHONN says that she can't. Now, that same GYN patient who had a hysterectomy, if you call and say, can you increase her rate from 10 to 12, they'll say, sure, and they'll go and do it. No logic whatsoever to any of this, and again, we have argued about it and made no progress. So this is where things stand, and again, this is why the labor nurses reluctant, unwilling, whatever you want to call it, to help you. And I'll just say, you know, since these guidelines first came out, now almost 20 years ago, we have over and over and over again tried so hard to get them to listen to us, and they are just kind of uninterested. So, you know what they say, what doesn't kill you only makes you older. And then just to talk a little bit about the ASA guidelines, there's a multitude of them that have to do with OB. You can see a long list here. You can find all of them on the ASA website. The new website to me is horrible. It's very confusing and hard to find things. But if you go to resources, under that you'll see standards, guidelines, and statements. You don't need a password. You can access them. You can print off a PDF form. And these are all the different ones. So there's the guidelines for neuraxial anesthesia and obstetrics, which is very administrative, like, you know, somebody needs to be readily available during the running of the epidural, et cetera. There's a statement on non-obstetric surgery and pregnancy that I talked about during the first lecture yesterday. Pain relief during labor, saying that, you know, all women have a right to good pain relief if they ask for it. There's the respiratory depression guidelines that have just been updated, and the infectious complication guidelines we talked about a little bit yesterday. And then I'm just going to touch on the practice guidelines for obstetric anesthesia. The updated version came out in February in the journal I've jumped ahead of myself. So this is the update from the respiratory depression guidelines. And I want to point out two things. One is that they say very straightforwardly that epidural opioids are preferred to parenteral because they reduce the risk of respiratory depression. Now think about that for a minute. I think a lot of times we've been very hung up that intrathecal or epidural morphine is more dangerous and needs more monitoring and is more likely to cause respiratory depression. Not true. The data shows that we get into trouble far more often with parenteral opioids, PCA, you know, intermittent IV boluses, whatever, than we do with neuraxial opioids. And these guidelines state very clearly that those are preferred, the neuraxial group. Second thing I want to point out is what the monitoring rules actually are for morphine. I think sometimes people have a mistaken impression that, for example, you have to be on pulse oximetry. They do not say you have to use pulse oximetry. We certainly don't in my hospital, and I don't think most people do. They say you do need to have some measure of adequacy of ventilation and oxygenation, but that is as much the nurse walking in the room and counting respirations and noticing she's not blue. That's really all it requires, and I think that's really what most people are doing. The monitoring specifically says once an hour for the first 12, every 2 hours for the second 12. So that's the standard for what morphine monitoring needs to be. In other words, you have to monitor, but it does not specify exactly what monitoring you choose in your specific unit. Okay, now back to where I was a minute ago. So these are the updated practice guidelines for obstetric anesthesia. If you're familiar with them, they really haven't changed much. There wasn't enough new randomized controlled trials out there that we could add a lot of statements or strengthen statements that we had in there. Now, if you've ever tried to look at the ASA practice guidelines, there is so much gobbledygook in there. There's like pages and pages of methodology and statistics, and it's really hard to get you to just tell me what to do. That's all I want to know. Just tell me what it is I'm supposed to do. In each of these, there's an appendix. It's always Appendix 1, and that has the recommendations, the specific line by line, thou shalt do this, thou shalt not do that kind of things. That's what you want to go straight for. So in these guidelines, it's on page 281. The appendix, and I'll just run through quickly what some of the recommendations are. Again, very similar to what was in there before. We updated some references and made the wording a little clearer, but other than that, the recommendations themselves are very similar. So it's divided into peri-anesthetic evaluation, what you would do preoperatively, aspiration prevention, which we talked a lot about yesterday, MPO guidelines and such, L&D care, retained placenta, we made a separate section because most of us felt like that's one of the more difficult cases we have to do. You get called stat into a laboring room, somebody's bleeding, they have a retained placenta. Choices for labor and delivery, postpartum tubal, and then emergencies. So in the peri-anesthetic evaluation, I think this is pretty straightforward. You need to examine the patient, at least do a brief heart-lung airway kind of a look at them. Communication system should be in place, and this is like we talked about in the previous panel. Big source of both liability and adverse patient outcomes for us is that we don't communicate very well with the other teams on labor and delivery. So having a system in place to be able to talk with OB and nursing, whether it's huddles, morning reports, however you handle that. Pointing out that routine platelet counts are not necessary. There are still places that will wait to get a platelet count on a perfectly healthy patient before a labor epidural. You do not need to do that. Don't need to type and cross routinely, and type and screen only by risk factors. Most patients are not going to need a transfusion for their delivery, and you can usually pick out who's higher risk. And that fetal heart rate monitoring should be done before and after block placement, but it might not be possible to do that continuously while you're actually placing the epidural, depending on what position the patient's in. In terms of aspiration prophylaxis, we talked about this quite a bit yesterday, but clear liquids are fine for uncomplicated laboring patients. In my hospital, a routine healthy patient expected to have a vaginal delivery gets a clear liquid tray from dietary, and then they can have anything that's on that tray. Women should be MPO for 2 hours before scheduled surgeries. You can restrict parturients who have risk factors where you're worried about maybe having to manage their airway, whether that's because she has diabetes or a non-reassuring fetal heart tracing or she's very obese. Solids, no in labor. No in labor. We still are maintaining a very strong stance about that. Maybe that'll soften in the future, but I just don't think we are there yet. And before surgical procedures, at least consider some kind of aspiration prophylaxis, be that a clear antacid or an H2 receptor antagonist or metoclopramide or whatever you like to use in your practice. Now, analgesia for labor and delivery is a tough one because that's such a personal choice for the patient. So it's not like we're trying to mandate what everybody should have for pain relief in labor or what an anesthesia group should be able to provide. So we were really worried about how we worded these things and tried to stay away from that whole piece of it. So the things that are in there is that you can counsel patients that the timing of epidural placement is not going to increase the incidence of cesarean delivery. If she's miserable and uncomfortable at 1 or 2 centimeters, that's fine. She can have her epidural. It's not going to change her C-section rate. That you should consider placing an epidural early for high-risk patients. So the woman with twins, severe preeclampsia, the woman you evaluate who has a very difficult-looking airway or is very morbidly obese. And when you're using some kind of catheter technique like an epidural, that your goal is to have her comfortable but moving. So minimizing motor block by using the lowest concentration possible to do that. Always using pencil point needles if you're going to do any kind of a spinal technique because of the high risk of headache. And then talking about PCEA with or without a background infusion as being preferable to continuous infusions for all the things that we talked about before. To just show you, throwing this in for labor analgesia, this woman walked in, I was covering labor and delivery that day, and the CRNA who was on with me, she called me and she said, "You got to come see this." And so she had just sat the patient up and exposed her back, and it's like, oh my goodness, look at that. It wasn't quite anatomically correct, but we got her permission to take a picture, and I thought, wow, that's really impressive. And it looks like it really hurt, doesn't it? Again, retained placenta, talking about the fact that heavy sedation is not wise in an immediately postpartum patient. So if you happen epidural, great, use it. And if you don't, consider a spinal if you need it, or general anesthesia if you're looking at major hemorrhage. And talking about nitroglycerin is probably being better than terbutaline and definitely more practical than a general anesthetic if you need uterine relaxation. Anesthesia for cesarean, supporting the idea that labor and delivery should have the same quality of equipment and personnel as our main PACU does in the main operating room, that we don't need the hand-me-down machines and we don't need all the cast-off monitors, that we need as good of equipment and facilities and support personnel as we would have for any patient we took care of in the main OR. Neuraxial techniques preferred usually, but general anesthesia may be more appropriate if there's things like a cord prolapse or a severe hemorrhage, et cetera. Again, pencil point needles. Maintaining uterine displacement. Don't worry about fluids before your spinal. They don't make any difference anyway, so just pick a number and use it. Both ephedrine and phenylephrine being acceptable pressors, but phenylephrine may be better if mom does not have a bradycardic heart rate in terms of neonatal outcome. And again, neuraxial opioids are preferable over parenteral. They're safer and they work better. So, you know, again, in terms of C-section, I think there's always going to be cultural preferences, and the one thing we can probably say is that, you know, faster the better. And then postpartum tubal ligation, treat them as an elective procedure, so same NPO guidelines as you would use for any other elective case, remembering they may have a full stomach if they did receive opioids during labor, individualize the anesthetic, but usually you're going to consider an underaxial technique, and don't attempt it if you've got 15 other things going on and the acuity on the labor deck won't allow that to happen. Hemorrhage, type-specific or O-negative blood, cell salvage, all these things are acceptable and should be used. Airway emergencies we've talked about, but having a strategy and equipment close by when you're doing procedures. And finally, CPR, again, we talked about extensively, but performing a C-section if you don't have return of spontaneous circulation within 4 minutes. And I'll just close with that. This is a nice ad that the ASA put out as part of their Lifeline campaign and emphasizing the important work that we do as anesthesia providers. I don't know if you can read the wording, but it says, every mother cherishes her first moment. She held her newborn baby every day. Obstetric anesthesiologists across the country use years of training to I can't read it, but anyway, safe care for mothers and babies. There you go. So anyway, nice picture, nice statement, nice sentiment, and thank you very much.